Good day and welcome to our third session in our series of ASTARISQ, addressing systemic racism to improve safety, quality, and trustworthiness in health delivery systems. My name is Hillary Edwards. I am the director of the Patients Professors Academy, and I'm thrilled to welcome you to our third subject on overcoming systemic racism and bias in providing quality care. You won't be hearing much from me today because I'm going to be turning it over to Dr. Jasmine Cooper-Williams, who's the director of qualitative research for the Patients Program here at the University of Maryland School of Pharmacy. Dr. Cooper-Williams leads the qualitative patient-centered outcomes research, particularly centered on research specializations of racialized health disparities, media, power, and discourse, as well as structured gender, economic, and racial inequality. She earned her MA and PhD in sociology at Michigan State University, along with a BS in African American Studies with concentrations in intersecting racial, gender, and economic inequalities in the U.S. Dr. Cooper-Williams, take it away.
Thank you, Hillary. Good afternoon, everyone. Thank you for that wonderful introduction. I do appreciate it. For today's talk, our talk is entitled Overcoming Systemic Racism and Bias in Providing Quality Care. And we have an all-star panel here today, and I'm going to turn it over to each of them individually to provide their own introductions of themselves. And so I'll just start with the roundabout that is appearing on my Zoom screen. Dr. Lou Hart, if you would mind introducing yourself first.
Absolutely. Thank you so much. It's really great to be with you all and have this opportunity to speak about what I think will be a pretty thought-provoking session. I know some of our preparation work has really racked my brain, and I'm really excited to delve in with you all. My clinical background, I'm a pediatric hospitalist here at Yale New Haven Health System, and I serve as the system's medical director of health equity. I'm really excited for this opportunity.
Okay, next up on my Zoom screen is Angela Thomas, and then Christopher King and Melina Da Silva. So we'll go in that order.
Hi, everyone. I'm Dr. Angela D. Thomas. I am the Vice President for Healthcare Delivery Research at MedStar Health. In that role, I oversee the evidence base behind how we deliver better care, higher quality, safer, more effective, more equitable, more innovative care. I have a funky blend of operations and science. So my science and research focuses on the intersection of patient safety and health equity. And I also oversee both an executive leadership capacity as well as scientific interest in our DC Safe Baby, Safe Moms initiative, which has a focus. It's a $30 million initiative focused on reducing adverse maternal and infant health outcomes with a specific emphasis on reducing disparities in that space. So really excited about this particular conversation, new friends, old friends, and let's get into it. Thank you, Jasmine.
Thanks, Jasmine. Hello, everyone. My name is Christopher King, and I am the Dean of the School of Health at Georgetown University. And my work is at the intersection of healthcare delivery, public health, and systemic racism. And so I'm really excited for the conversation that's about to transpire. I know we're all very passionate about this topic, and we're using our lives to leave the world better off than it was when we arrived. So thanks for having me.
Good afternoon. My name is Melina Da Silva. I'm a MedPeds trained physician, and I work at Health Partners in Minnesota, close to Minneapolis, Minnesota, so the Twin Cities area. I'm primarily in the Health Partners Institute, and my research focuses, much of it is on vaccine safety and efficacy, but I also have a grant through the Centers for Disease Control and Prevention, focusing on newcomer populations, so refugee, immigrant, and migrant populations, and looking at issues related to language access, as well as granular demography and how location and time where you've spent your life impacts your health risks, particularly from infectious disease standpoints, as well as chronic disease risk. I also work in the Health Partners Travel Medicine clinic, and I see patients at one of our local county tuberculosis clinics, where I primarily see non-English language patients.
Thank you all for being here today. I'm very excited as well about this panel. It's, as Hillary said, an all-star panel. So I'm excited to get right into the discussion. As we're beginning our talk, I'd like to clarify some of the terms that we use when having this type of discussion. We tend to throw around the term race and racism, bias, structured racism. I'd like to get some clarifying definitions from the group about what those terms mean and why they are significant to what we're talking about today. So to begin, anyone can jump in here. What do those terms mean? What does race mean? And how does it relate to delivery of healthcare? What does racism mean in the delivery of healthcare? So I'd like to kind of begin our discussion there, and anyone can jump in.
I'll kick it off.
Thank
So
you, Dr. King.
race is based on an 18th century classification system that was intentionally designed to oppress people of color. It is a social construct, right? And when we think about healthcare, unfortunately, because of the way that history has, just evolved, race is used as a key driver in clinical decision making. Unfortunately, I think we're getting better at it, but we have a long way to go. We know that people's health is mostly shaped by the conditions in which they live, learn, work, eat, and play, right? And so it's important for us when we use the language, the word race, that we are appropriately contextualizing. And what do we mean when we're asking for a person's race, and how are we using that data? We have to be very careful with that.
Go ahead, Dr.
I'll piggyback on that definition, and I couldn't agree more in terms of its background, its relative recent history as a use or as a tool to classify humans. To your point, it being a socio-political tool. It was made up by humans and used to govern humans. And it was really based on physical, cultural, or social differences. And this was kind of during the European Enlightenment movement, which is kind of ironic to say, where the naturalist movement really, we wanted to start classifying plants and animals into different species and genuses, a taxonomy of kind of ordering the world around us. And as imperial powers began to spread further away from their lands, they found people that look a little different than them. And they realized that if we are to extract as much value from these lands, we probably need to subjugate these people in the quickest way to be able to derive as much benefit from our pursuits. So in that regard, when we say social construct, it was human-made, man-made, woman-made, person-made, and it was used as a political tool to really classify, create a system of categorization of humans. And I think an interesting point here is that racism predates race. These beliefs of innate superiority or innate inferiority in certain groups predated the need for us to classify people as different. We wanted to find some type of meaningful system beyond just these imperialist desires to oppress and to subjugate and to really extract value. And we looked to the natural scientists, we looked to political philosophers, and really early medicine to really create this idea that race might be biologic. And it was our racism that used something empirical we could see as race as the driver of, see, these people are inherently different. Let's actually classify these humans on a hierarchical worth scale and say that people who are at the bottom, who are at the lower levels of this person-made system of classification are less worthy. And that somehow your skin color or your eye shape or your hair texture had meaningful biological importance beyond just the things that you could see, that it somehow represented some greater value. They didn't really understand genetics at the time, but some potential greater value of hierarchy and pedigree that would be denied from some persons and obviously bestowed on others. So it is a really fascinating history and a relatively recent development in humankind. There were no races before the 1600s. This is a relatively new system of classification that was absolutely man-made. There is no biological value to race in the human species.
These are great points. It's interesting too, because I'm thinking about the classification system. I'm thinking about the power and privilege that are assigned differently based on where you've been placed in that classification system. But to your other point about the history and the development of the categories and the pseudoscience that was used to back up these categories later, your points are very well taken. Thank you. If anyone else wants to chime in before I move to the next question, please feel free. Otherwise, I'll go ahead and move on. Okay. Now, I guess my next question is, in our discussion of race, is racism alone a sufficient cause to understand health disparities? That is, can we address racialized health disparities with an understanding of racism alone as we've defined it? Or is there more? Are there other intersections that we need to address? Does it go deeper than just that? Are these systems mutually reinforcing one another and creating different outcomes for different groups based on where they find themselves? So that would be my next question. Is this discussion of racism alone sufficient to highlight and to redress health disparities, or are there other intersections that we need to consider as well?
Well, I would say alone, with the emphasis on the word alone, I would say it's inefficient, but I don't think you can have a discussion about health disparities without appreciating not just the role of racism around just health, but how embedded that is in every aspect of life that then contributes to health. And then I know, speaking your love language, Jasmine, is then how does that intersect with other demographics and other pieces of life, and how people move and navigate in the world? How does it intersect with gender? How does it intersect with class? And how does it intersect with gender identity as well as sexuality? I mean, and the list goes on and on. And so I certainly believe the conversation can occur absent a discussion of race, but I don't believe that race is the only thing that should be discussed in the context of health disparities.
Thank you, Dr. Thomas. Very good points. Anyone else want to chime in here? I'm going to start calling on folks. I don't want to feel like I'm back in class again, but anyone else want to chime in here on this discussion?
I'll offer a couple cents. Oh, Melina, you wanted to come to the conversation?
I was just going to, I agree that it's insufficient to say race alone or racism alone can explain these health disparities, that they need to be taken in consideration with the other phenomenon going on. For instance, one of the variables, or one of the demographic factors I focus on, is language access, and how people who do not read or speak English receive healthcare of lesser quality. And we know that that's a reason that we don't integrate appropriate interpreter services. And this happens to intersect with race as a way, but thinking through intersectionality with socioeconomic status, and thinking through the multiple ways race and racism have been embedded within our culture, that you have to think through it in a multi-level way. So not just saying racism alone, but thinking it through how it intersects with multiple other areas that do impact health and health delivery, receipt of care, as well as outcomes.
And again, I completely agree. I feel so awesome to be a part of this panel, because there's so much truth being spoken and shared. I think it's, as racism, one of America's original sin. I mean, our genocide of the native indigenous persons that were living here, our mass transportation and exploitation of enslaved people from West Africa, and then the forced labor camps that we set up that really started our nation off on a capitalistic footing. It's when we leave it to the biological sciences, or the clinical practice of physicians to really try to understand, we really don't like multifactorial. We want to find one true answer, and we want to put it into buckets. We like to deduce things and really turn things into their simplest forms, and really assume that there's just one size fits all. This is what's going to work for everybody. So I think as we peel away the layers of this onion of what the multifactorial, the multitude of reasons that are driving differences in experience, process, and outcome, I think it would be naive to be absent of racism. Given our country's infamous legacy of racial discrimination, it's probably one of the most difficult ones to really deal with. So it's kind of ironic that it is probably the most important one. That is not to say that other intersectional systems of oppression, ableism, sexism, classism, absolutely intersect with being racialized. So I wouldn't want to say one is more important than the other, but one has, they all have very long legacies. And I think it would be naive to try to chalk it up to just one simple approach fitting all. But I think it's very important to understand that, Dr. Thomas said, a conversation about a disparity without an understanding of our history and the sociology that created this difference is naive. And I feel too often in understandings, the sociologists and historians have been left out of the conversation. And it's been led by, the biologists who are really trying to provide quote unquote objective empirical data without the context in which that data was derived.
And I just want to add, this is complicated work. It's very complicated. And we as humans have this natural tendency, as you're saying, Dr. Hart, to want to put things in buckets and put things in classifications. It's very normal, right? But we're better than that, right? We know that this is very complicated. Intersectionality is real. There's all these different forces that shape people's lived experiences. And what a disservice for us if we're going into patient settings, for example, just looking at one or two variables, right? It's a lot that we have to consider. And in my work, I'm always thinking about what role does the healthcare delivery system, how do we shift? What's the paradigm shift that's needed in our nation's healthcare delivery system? Because it's very biomedically focused, right? And you have physicians and these medical providers that are expected to address disparities. We know that's not going to happen. This is much bigger than that, right? We have to think beyond the walls of the institutions in which we operate. We have to think also how racism how does it show up within our institutions alone? And how does it show up in our communities? And what role do we play in addressing that? And so it's very complicated. It's heavy work, but it does require us to reflect on our history, unpack the policies and practices that put us in this place. And through that knowledge, I believe we will be inspired for new policy, new practice. I call it atonement in policy, atonement in practice to address the issues so that all people have environments in which they can live well and thrive.
Dr. King, I like that point about atonement. I wonder if you could speak a bit further to that. I was going to get there a little bit later in the conversation to something simpler, but you already got there. So let's what does that
mean? I'll give some examples. I mean,
yes,
so at Georgetown, we have done the work and we continue to do the work. We're looking at the names of buildings. We're looking at our environment and we're asking questions. Who are these actors? Are these bad actors in history or not? And so we started the process of changing the names of a couple of our buildings. So to me, that's a form of atonement. It's like, how do you fix for the past? How do you own it? And that's the work that we're doing. So some would say reparations would be a form of atonement, right? But what does that look like? Mm-hmm. But it's really thinking about, this did not happen by coincidence, right? This happened with intentionality. Mm-hmm. And I think when we all realize that, all of us, not all people, will be in a better place. And that's the work we're doing with our students at Georgetown. We really are going through the history of the country. And through that lens, we think that we will have a new generation of practitioners that are much more compassionate. They understand, they're asking the right questions. They're going into spaces with humility, knowing that they don't know all the answers, right? What does that look like? And so those are some examples of what atonement can look like in practice.
Indeed.
I'd love to quickly, if I have the opportunity, just to add to that. And I think, like, to your point around like the naming of buildings, I read recently that there's now going to be an Emmett Till memorial. And I just don't want us to lose the long-term vision that this is like the prelude. This isn't even the start. This is before the start of work. Because we don't want to say, this was good enough, because all these things are symbols. And yes, symbols are important, and yes, they set a tone, but unless we're actually going to follow up those symbols with real change, policy reform, voting rights security, housing, guarantees, universal healthcare access, not just insurance, those are the things that are actually going to move the needle. I agree, you can't have those things without at least doing the quote unquote earlier or low-hanging fruit, but I know it was Professor Derek Bell who really touches on this really well in one of his pieces, Faces at the Bottom of the Well. In the first story, it talks about just looking at some of the things that we were trading and what you perceive as value, someone is giving you easily and happily and readily, understanding that if that appeases you, that symbol appeases you, then they never have to do the real work that's going to follow.
And very quickly, just after George Floyd's murder, CEOs of hospitals and health systems would run their philosophical statements, their anti-racist statements by me. They wanted to get my endorsement. And many of them were very eloquently written, well done, just perfect. But I would always push back and say, okay, this is wonderful. Where's your action? What are your action items? What are you measuring over time? And how are you being transparent and sharing that with the community in which you're serving? If you're not ready to do that work, then you're not ready to release this statement, because the community is watching, the community is listening, the community is tired. So, Lou, I couldn't agree more. The symbols are symbolic, and that must be followed with action.
Absolutely. This is a very fruitful discussion already, and I am loving being a part of it. So moving further into tapping into your expertise and your experiential knowledge, each of you, what have been some of your direct experiences working where you work, working in healthcare delivery, working in the spaces that you work of public health and healthcare, where the impacts of systemic racism were absolutely and abundantly clear, whether it's through your engagement with your patients, through your own treatment by someone else and the system itself. What were some of your experiences looking back at your own history that illustrated the impacts of systemic racism within the healthcare delivery system?
I can start. I'd like to begin mine with framing my actual personal experiences, and not necessarily within my health system, but just my experiences in intersecting with healthcare today. Despite the 4 degrees behind me, I know that as a Black woman, how I dress and if I put the doctor in front of my name or not could impact the care that I receive. And because it has impacted the care that I receive. And I am fortunate to be able to change my hair or change the way that I dress or put doctor in front of that to help mitigate. And that's been the case my entire life. Like there's always been a feeling of an experience of treatment by the way that I show up. I remember having a cardiac issue as a young teen mother and driving myself to the emergency room with my son and being shamed by the providers for driving myself with my son. And I never will forget that feeling. I remember seeing a behavioral health professional after being a teen mom and having lots of assumptions about how I landed there made about me and not being able to benefit from what is very valuable in the perinatal space of behavioral health support. And so I show up to my career, I show up to my science, I show up to my organization, understanding that these are real experiences and more of the patients that we deliver care to. So when I show up to my science, I am looking for differences. I'm looking for what is the data telling me that it could be indicative of differences quantitatively and go deeper qualitatively to hear about those experiences. And we've done that in the patient safety space. Where we've noticed that there's a difference in the reporting of patient safety events when the patient is Black versus when the patient is white. We've done that in the maternal health space where we've seen the disparities and go deeper, and they talk about differences in the care received, and it does differ across race, ethnic lines. And so unfortunately, it isn't surprising because it is very much I look at the data through the lens of my own experiences, and I use those own experiences to fuel my curiosity and willingness to keep moving forward.
Thank you, Dr. Thomas, and thank you for sharing that element of your story as well. Like, I really do appreciate that. Anyone else, Dr. Hart, Dr. De Silva, Dr. King, would like to speak to this?
I can speak from a clinical perspective as far as tuberculosis care and how U.S. immigration policy, I think, impacts the care that patients receive, at least patients that I see on a regular basis, whereas the refugee population is one of the most highly, screened populations for coming into the country. If you come in through a different status, through family reunification, you have a lower level of medical care that's provided or screened for before you come in after arrival, and also access to the healthcare system. There's navigators that help newly arriving refugees, and the same isn't true for people who come through other mechanisms. And for undocumented individuals, there's no established, screening or availability of medical care to them or in health insurance. So just thinking about what policies are in place currently that impact the health of our immigrant populations in the United States. I think it's also through that lens that I think about how people are appropriately screened for things. So many primary care doctors don't realize that patients coming from certain countries need to be screened for hepatitis B, which can be a chronic lifelong condition that impacts your health, that can lead to cancer. They don't realize you need to be screened for tuberculosis. And if they had been screened for tuberculosis earlier, then and provided treatment for a form of tuberculosis that's not infectious, that they wouldn't develop it and then spread it through their communities. So thinking about who is at risk for disease because of immigration policy, I think from the work that I do is apparent on a daily basis.
And I just want to add, we all know this work and what we're dealing with, but there's some moments in our careers that it really hits us. And I'm going to share very briefly one of those moments I had. I had to speak to a board of a healthcare system. And the board was, as you can imagine, predominantly white males. And after that board meeting, I had to go to one of the hospitals that was part of that system. And I was meeting with an ER physician. So I get to the emergency room and I look at all of the people in that emergency room, and they look like me and members of my family. And I thought, those folks I just spoke to are making decisions about this population. The voices of this population are not represented in that boardroom. How in the world are they going to make the right decisions about how to best meet the needs of this group? And so that was a major moment for me. I'm just like, wow, we're missing the mark. And this is not going to be fixed until we have people from the community in the highest levels of leadership. And I'm not just talking about successful, if you will, however we want to use that or define that. I'm talking about grassroots folks who know the community, and when they say, meet me at this church at 6 o'clock on Sunday, people show up, right? Those are the people that need to be a part of the conversation when it comes to how do we improve the delivery of care in this country. And we're seeing some movement in some spaces, but we have a long, long way to go. So that was just a moment for me. And I remember driving home just like, wow, I have my work. We have our work cut out for us.
Thank you, Dr. King, for sharing that, Christopher. It's, I think this is something that we say here often, that data tells the story, but our patients will tell the truth. Too often it ends right at that quantitative data extraction, because that's really easy for us to do. It's really hard to ask people what they think, how they feel, because we don't really know what they're going to tell us, and we don't know if we're going to be able to meet them where they are. But until we force ourselves, that truth and reconciliation process will never start, which will ultimately lead to this. I think kind of in my experience, I was born and raised in Western Canada. I moved to America when I was 12 years old. So when I grew up in Canada, I was just a tall Canadian. Now, as soon as I moved at 12 years old to New York City, I was a young Black man in this country. And it was a very different frame shift. And it was the experience, the awareness that I was relatively naive of in Canada was something that became readily apparent. So when I decided to do my residency training, after spending 4 great years out at the University of California, San Diego, surfing and eating avocados, which I'd never done prior, I decided to move back to New York City. And I did my residency at NYU because we were promised to spend half our time at Bellevue, which is the oldest public hospital in our country. And I thought, this is amazing. Like, we're going to have a public hospital that's going to have all the access to NYU doctors, like, academic, well-resourced institution. And just to notice that, like, wow, we have really segregated the types of patients that we care for. If you are a new immigrant to the country, if you speak English as a second language, if you are disproportionately covered by Medicaid, you're going to get seen at Bellevue. And if a lot of those criteria, if you were white, if you had resources, if you had private insurance, disproportionately you were seen at NYU. And I don't think this was a policy, though this is the kind of structured element of this. We've segregated our care because of reasons why a safety net hospital even has to operate, because the quote unquote non-safety net let them fall through the cracks. And this idea that like healthcare is more a manifestation of all of these societal woes and societal injustice. Are we the only driver? Are we the principal driver? Well, we do make up the largest percent of federal budget spend every year. Around $2 trillion is spent on US healthcare, more than we spend on public housing and public education combined. Are the inequities that we waste in healthcare. Around $320 billion on a yearly basis are wasted in healthcare inefficiencies and inequities. So I think like if we think about like healthcare playing a large role, yes, but there's a groundwater problem because the same disparities that we see in healthcare, we see in education, we see in criminal justice, we see in money and banking, we see in child welfare systems, as the Racial Equity Institute puts on very well. This is much deeper than just any one system, and we need to make our systems more interdependent so that we can start to acknowledge the things that are driving all of these differences that we see, as opposed to just trying to whack-a-mole where we see it. Because if we just fix it in healthcare, it'll quickly come back through that toxic groundwater, and we'll start to, if we don't fix the finances, the housing, the lived communities where people spend the majority of their time, and we cure their diabetes in the short term, the next generation are going to come back with even worse pathology. So that's the first example. And the second example quickly is the use of race-based medicine. And when the NIH started asking researchers to include demographic data on their research subjects, this was accepted as an opportunity to end inequity, end injustice in our country. Unfortunately, researchers, I think many researchers at the time didn't really understand what that race variable was. They thought it was objective, they thought they could just associate it, but they didn't understand what other confounding variables they were attributing by racializing their data set. And in doing so, they found differences, and they interpreted these quote unquote, what we would now call today disparities, unjust differences, or differences would be more inequities or unjust differences. They looked at these disparities as fundamental, as innate, as immutable. And thus, these must be biological qualities of this subset of the human species, which is so far, it's so sad that that was kind of the early knee-jerk reaction. So what we've done is we've normalized disparity and saying, when it comes to lung function, if you have a level of a 3 and you're Black, that's normal. But if you have a level of a 3 and you're white, that's sickness. We've normalized this difference as opposed to saying, wait a second, you are much below the standard. Not just that it's normal for your group to be at that lower standard, that's not normal in the first place. But the earlier understanding was, well, these differences must be meaningful, and I think that short-sighted approach has made us. I can list you 15 other algorithms that take someone's race into account, and very few times are they ever to the benefit of that racialized, minoritized population. They're just we found objective data out of an unjust world. How objective can that data be without the context? And we're just going to assume that that's the way it has to be, and that's the way we're going to predict it going forward, which is an exact example of structured racism in our healthcare system. The fact that we treat you differently on the basis of your skin color, even though that violates Civil Rights Act of '64, it violates the Affordable Care Act. I mean, I don't know how we're getting away with it. I think it's because we're not telling our patients that we're doing it.
Wonderful points, Dr. Hart. And actually, you led into some of the next questions that I was going to ask. And I do see a question in the Q&A. I'm going to ask probably 1 or 2 more questions and then start getting to the Q&A questions. So folks who are attendees, if you have questions, please feel free to pop them into the Q&A because we'll be getting to those in about 5 minutes or so. But before we get to that, Dr. Hart, you addressed the ways that race is studied. What about, in connection with that, what about the ways that new health professionals are trained, right? Because if this is the scholarship that's out, this is part of the training that you've received, right? So what about the ways that new professionals are trained, and how does that continue to perpetuate the existing barriers that we see with regard to racism and health disparity, not even just health disparity, racism and racialized bias within health systems? I guess that would be my next question.
I might be able to speak to this a little bit, given that I do have a teaching role here at the Yale School of Medicine. I'm an assistant professor in the Department of Pediatrics, so I do have the privilege to be able to have class with medical students. I teach a course at Yale University, and I think the hardest part is that for the majority of, and not unique to here, but of the many institutions I've been at, for the majority of faculty who have been in academic and teaching roles for a long time, this is much newer to them. And for the student body, the younger medical students are like demanding these things in their curriculum, demanding when I go to grand rounds and someone brings up race, give me a hypothesis for why you thought you would include this. And what were you using race to measure? We're using it as a poor proxy for racism because we know that two people of the same skin color aren't at the same risk for racism. There's other intersectional identities that further dispose to a bad outcome. So we know that, the majority of the people that have the opportunity to teach are not people who had that education themselves. So I think it's a piecemeal approach. I think that's going to change over time as more, junior and middle career scholars rise to the level of professor and begin to have, protected time to be teaching the younger body. I am excited to see, though, that medical students are just not accepting dogma as fact anymore. I remember when I was in medical school, he was drinking out of 2 fire hoses and I was just trying to open my mouth both ways, accepting that somehow, my kidney was different because I was half Black. And I was like, do I get half the equation because I'm half white? Or is it just kind of all the equation? And I asked 300 people in this lecture hall and they kind of just looked at me and be like, Lou, stop talking. And the professor's like, I don't have the answer. We're just moving on. And I'm like, I guess I just have to accept this dogma as fact. And it really wasn't until I was a little bit later in my residency training that I was like, why do we do the things that we do? Have we ever questioned what we do and what we just accept as tradition? Because traditions can be great, but traditions can get better. And it's important for us to understand that history of the past to be able to make a better future. So I would say that the younger generation of medical students, those who are earlier in career, are more from they're more socially aware. They grew up in the era of internet all the time. It was hard to be ignorant of or naive of this type of information. They're demanding for this. And now it's up for kind of esteemed, bastioned institutions like nursing schools and medical schools and, PA schools to really be able to rise to the occasion. Because if they don't, from a competition standpoint, people are going to go to medical schools and nursing schools where they can get the education that's going to make them a better, practitioner. So I think that it's the demand for more, and it's the kind of, the shifting sense of awareness that is happening in these elite institutions. And, I think any professional school is an elite institution, no matter what the name on the door is. So it's important that, success will be when I open a journal article in New England Journal of Medicine or Journal of American Medical Association, and I see a high impact journal like that publish a patient story and a patient's experience. And patients are the one writing academic literature so that us as clinicians can read from our patients. Because I don't need to hear another clinician tell me about an opinion that they have. That's all I've done my whole career. I'd love to hear from patients and how this is doing for them. Because at the end of the day, they are the ultimate stakeholder and constituent.
Yeah, I just love our young people. They are really pushing us to do better. They are not having it. We actually have a process I know it's at the med school. We're doing it, I think, in nursing and also in some of our programs where we tell our students to call it when they see it. When they see race being used as a key driver for a decision, call it out. Say something to your faculty member. There's a place that they can go virtually and they can document it and can go, it'll be confidential so that we can address it. And so again, it's the students that have been unfortunately leading, fortunately or unfortunately, depending on how you look at it, leading this work. And they're just not, and it's not just students of color. We're seeing white students ask questions. Again, after George Floyd's murder, when students came back to our campus, and I'm sure I'm speaking for many other universities, they demanded a better educational experience. And so thanks for asking the question. Training is very, very important. I know that a study was done just a few years ago where they asked residents and some students about biological fallacies. The study was done in 2016. And we would still see evidence that folks thought that Black skin was thicker and Blacks had a higher pain tolerance and the skulls were different shaped. I mean, anyway, the question is, were they explicitly told that? And I would argue that they weren't explicitly told that, but it's deeply embedded in curriculum. Right? It's deep-seated in curricula and the history. And that's where it comes from. And so it's important that we chip away at that and that I call them critical audits. We do critical audits of our teaching and we're doing it through a racial equity lens. And so that's work that I think every institution needs to do. And this goes beyond the healthcare sector. You can do this in education. You take the sector. But we all need to go through this exercise of reflecting on our work through a critical audit using a racial equity lens.
Thank you, Dr. King. Yeah, I appreciate that point that you made, because we're talking about healthcare delivery, but at the same time, it's operating within a system that has been historically racially unequal. And not only is it historically racially unequal, but the ideologies that have been used to support this system continue to perpetuate themselves throughout this system, whether we're looking at media or other spaces. So to your point, yes, I fully agree, and I see a lot of validity in what you've said. Before, because we are at 1:41, and I said I wanted to switch to the Q&A. So again, participants, please make sure that if you have questions or comments or ideas, that you're popping them either into the chat or to the Q&A. And I want to shift gears and answer some of the audience questions as well. So we have a question, or yes, a question from Patrick G. That says, as each one of you are experts in your own right, can each of you share your strategies for removing race from healthcare and replacing it with your consideration of humanity?
I'll start. So I find myself, I would say in the past few years, having the following conversation. So there is a body of literature that talks about the importance of concordance, and race concordance for this conversation we'll talk about, and how, in some studies they found that there are better outcomes when the patient has concordance or has the same, identifies in the same way as their provider. And so there's a movement on one hand to push toward how do we increase concordance? But when you look at the reality of things like medical school enrollment to the number of patients that need to be cared for, we're just not there where we can get full concordance. So I find myself saying the following. Well, I've had wonderful experiences with folks who look like me and horrible experiences with folks who look like me. And when I come down to the why I had great experiences, and I've had great experiences with people who don't look like me. So when I look at the why of when I have great experiences versus when I don't have great experiences, it boils down to being listened to. It boils down to the person seeing my humanity. It boils down to the person really coming to the table to help Angela and all of who Angela is. And really recognizing my humanity and having a human to human interaction. And so my conversation has been, let's just talk about the it as to why we think the concordance matters here. It's the relatability. And we won't be able to relate to everybody just because we look the same. I don't relate to being raised in Canada, and Lou and I arguably look the same. And so we can't just put all of that in the box. And so when we come to the table with curiosity of the person and their story and their experiences, which to me is humanity care, then we can move the needle. And we have enough providers to go around to be humans, caring for humans. And so that's been my conversation lately.
Thank you, Dr. Thomas. I think something else, just to piggyback, I know I'm not supposed to be like interjected in the conversation, I'm just a moderator, but hearing your experiences, having my own experiences with my pregnancy with my son and recognizing there were definite disparities in how I was being treated. It's also the respect factor, right? Humanity, but also respect me as a person and respect the things that I'm telling you are causing me pain or are alleviating said pain. So as a patient, those are your experiences, are experiences that I connected to in a different way, because I recall being a Black pregnant woman in a space that I wasn't being heard about that pain. So I definitely appreciate what you contributed here today. Okay, was there someone else who wanted to piggyback off of that? I kind of jumped in, I'm sorry.
Yeah, Patrick, thanks for asking that question. I remember just not too long ago, I was giving a lecture and talking about race and it being a social political construct, and a student said, at the end, well, if it's a social political construct and we want to get rid of it, that's what he said. Why are we still collecting data about race and ethnicity? Like, why are we still asking the question? And so I paused and I said, who can answer that question? And the student said, because racism is real, right? And we have to continue to ask the question to identify where intervention needs to occur. I envision a world where we won't have to ask that question anymore. I dream of a world where we don't have to ask that question anymore because of our humanity, because we live in a world where people are heard, and it doesn't matter who the person is on the receiving end, as long as they are listening to me, they respect me, they want to learn about me authentically. That's all that matters, right? And so we will need to continue to ask these questions until we rid ourselves of this that but I thought that was a very insightful exercise and question that happened at that moment.
Thank you, Dr. King. Dr. De Silva, I saw that you wanted to chime in as well.
I think we also need to be cognizant of what demographic factors do portend health outcomes and how we collect those. So systematic collection of of language, what language you prefer to speak in a medical setting versus at home. Just because that's what I deal with so much, and use of interpreter services and how we incorporate some of those more telling predictors of a patient's health into how we're reporting data and what we think of as outcomes. Also, along the lines, same lines, that we need to be able to have, these standards communicated across health systems and come up with standards that are important to report on, in similar to the way race was decided upon to be reported on, thinking about what other variables should be reported on. And going back to your question about training, I think there are, there's not much training in medical school or residency about appropriate use of the ICD-10 codes, which end up being the way we identify so many outcomes, how large data sets are, the research is done with big data, and thinking of whether there needs to be more education about the use of those codes, which sometimes will include things such as like person experiencing homelessness or other demographic factors that really do impact a patient's health, and that should be captured, but we have incomplete capture of.
These are very important points. Thank you, Dr. De Silva. Okay, we have a couple more questions in the chat, and I do want to get to them before we wrap up at 2 o'clock. So there is a question or a comment or a question from Randy that says, to me, structural racism is obvious, but how do we move along potential allies whose current mindset remains, quote, I'm doing all I can by being completely colorblind?
I might try to take this one just because I just kind of responded to Patrick in the chat for his question. I responded in the Q&A, but I think it's the idea that the desire to want to move from race-based, which just feels wrong now. It was more culturally acceptable 60 years ago, and it was still even very debatable then, but it seemed like, it was much more the status quo then. And now it seems very wrong, even though it still shows up in very many places, just much more pervasive and much more insidiously. But the idea that we want to move away from race-based to this race neutral, we're in a post-racial America, we had a Black president, everything is good now. Things are a lot better than they were in the past. My father was born in 1955. He drank out of different water fountains in this country. That's an experience I've never had in this country. The things that I experience now are different. They've been restructured and repurposed in ways that are much more opaque. They're not as explicit and transparent in many of the circumstances, though they very much still can be. So I think it's an awareness of with that historical context, how might there still be lingering modern day consequences of what's happened in the past? And how might there be systems, like how we measure kidney function, that was based on ideology from the past? And how might we still be practicing under those pretenses today? So how can that awareness, or what is described as race consciousness, lead us not to just say, okay, I've identified you as Black and I'm going to treat you like all the Black people, or I'm colorblind, I don't even identify, I just identify you as a human, and I'm going to deny the complexity of what race might have or has not done to you as a person. There's probably a middle ground where it's like, now that I have this new piece of information, this unique personal piece of information about you, how can I continue to ask a better next question to get to know you better? Maybe race is a risk factor for racism, which is a better way of us asking, have you experienced racism? Has this shown up in your clinical care? Have you experienced it outside of our four walls, in housing, in the criminal justice system? And what ways can we partner with you as humans, as partners, as your healthcare or deliverer of healthcare? How can I care for you better with the awareness of everything that makes you you, not just the color of your skin, or not just imagining that you haven't been, that people who look like you weren't treated differently in the past. So I think we don't want to be race-based. We don't want to be race naive. We want to be race aware, but we don't just want to treat people based on their race. We want to get to know people better and start to understand, well, I use the example of religion. Not every Jehovah's Witness patient who's Jehovah's Witness refuses a blood transfusion. If I was just operating under religion-based, I would say Jehovah's Witness, no blood transfusion. I'm not even going to ask them. Not every Muslim patient that I've cared for doesn't want pork. So it just but when I have a patient who's Muslim and I'm reviewing the allergy, I'm like, is there any chance that you would like to avoid pork products? Because we had a recent case where someone got heparin, which is a blood thinner that's derived from pork. And the family was very upset because this would have violated their religious law. So it's not just saying all or nothing. It's saying, hey, I have another question for you based on the information you've shared that might allow me to provide you even better care. I'm not making any judgments, but I'm trying to make a better informed next set of questions so that I can make a judgment that is shared.
And to me, that's the evolution from cultural competence, because I remember in the 90s, we would go to these in-services, these mandatories, and we were told, if this person is Jewish, then X. If this person is Muslim, then X. I remember that. Boy, were we doing harm, right? And so we don't use the language cultural competence unless we're talking about the harm that's been done, right? And how it showed up in the past. But we're using the language cultural humility, which is what I think we've all been saying in our own special way, right? It's asking the right questions, respecting the person before you, having a curiosity about that person's lived experience, and asking deeper questions each time for each successive question, right? To really get to the core of what's needed to best treat that individual.
Thank you, Dr. King. And thank you, Dr. Hart, as well, for your comments. Everyone has given wonderful comments today. This has been a great panel. So very excited and grateful that you have shared this time. We have a couple more questions. There's one more in the chat, and then I want to ask just a question to round us out in our discussion and bring us to a close. So this question from the chat says, or the Q&A, do you get pushback from large institutions that you work for when trying to dismantle some of these inequities, and how do you handle this?
I'll start. The journey hasn't been easy, but I've handled it leveraging the things that I have found have worked in other spaces. Is relationship building. It's data driven. It's honestly being transparent about my own experiences and feeling psychologically safe to do that. It's been education. It's been having the difficult closed door conversations, and it's not perfect, it's creating, building my own trustworthiness with others, and it goes back to relationships to be able to say, hey, I don't think so there, or we might just want to look at this differently. Embracing diversity of thought, owning my own blind spots. So while I am a woman of color, I also come from a dominant religion of Christianity. I'm also a cisgender woman. I'm also in a heterosexual relationship. I also speak English as my primary language. I also don't have a disability I'm navigating. So I call those out so they can appreciate from me too, there are spaces that I don't understand. And I need diversity of thought to make sure we're treating everyone equitably. And so those things, I think in combination and probably plus some others, have been helpful.
Just very quickly, yes, Dr. Thomas, leading by example is key to this work. Can't agree with that more. I think the other piece that's important, this is very heavy work, right? And so I'm always trying to find the right language that pulls us together and not polarize us, because that can be very easy to do. And so, you know, I've seen folks who facilitate these conversations around race, and I've seen the train wreck, right? Because they did not have the language, the skill set to do this work. And so I am constantly trying to find the right language to help folks understand these issues and help them understand that we're all in this together. You know, I live in Washington, D.C., and if there's a part of the city that is historically marginalized and underserved, and I don't live in that part of the city, it's in my best interest for that community to do well, right? COVID showed us we're all in this together. And so the language is needed to make that happen so folks can understand that this is about all of us. It's about your children, it's about your grandchildren. No matter what background, your background, we're all on this globe. This is a global community. So that's one way that I deal with challenges when they face me.
I'll just add really quickly, and then just Dr. De Silva, I don't mean to speak over you if you wanted to join the conversation again, but just to Dr. Thomas's point around like embracing the diversity of thought. In this world of cancel culture, there couldn't be anything that is more antithetical or an impediment to improving this journey of equity than doing that, than saying, I disagree with you ideologically, thus you're bad, thus no more conversation. The second you just say, you're a racist or this is racist and that's it, it really ends the conversation. And there's really no constructive construction that can come. There's no collectivism that can become after that. I put the scarlet letter on you. You're eternally bad. There's nothing more to do. And if equity is all about meeting people where they are, how are we not being better at that? So it's important that we don't want to call people out. We want to call people in. It's interesting you said that. Can you tell me some more? And when you start doing that, you start to explore the full dimensions and the depth of people, because there is no growth in comfort and there is no comfort in growth. And like, no, this isn't going to be easy, but we want to press when it's hard, because I guarantee you what we get from it is going to be so much better than if we just had these superficial conversations. But this idea that like, they're fundamental, they're diametrically opposed, there's right and wrong. We're all learning, we're all starting from different places. So it's probably better served meeting people where they are and understanding that like you might be earlier in your journey and I'd love to learn from your perspective that has kept you, or that is maybe you're further ahead in a different way than me. I'm not saying I'm right or wrong, but I learn more from conversations with people who don't agree with me. Not that I'm not learning a lot today, which I am, but then oftentimes from people who have read the same books that I have or attend a lot of the same conferences that I do. And I really appreciate those opportunities to really learn and grow from people who I disagree with.
And I would just add to that, taking every opportunity to provide education, re-education is very important because the memory is short. And what I've found working in here, especially for language access, is that it's a long game and change is slow and you can't get discouraged.
Thank you all for those comments. And actually that kind of brought us to an answer, the last question, which was about strategies to inform change and to shift the needle with regard to systemic racism and bias in terms of healthcare delivery. But what wound up being discussed is ways that you each actively challenge the existence of these inequities in the spaces that you work in. So you kind of answered the question without me asking it. So thank you for that. At this point, I want to thank you again for your insightful contributions to this discussion. This was a wonderful conversation with a group of all-stars, and I'm just so grateful for the time that you provided to be a part of this roundtable. At this point, we are at time, so I'm going to turn it back to Hillary to close us completely out. And thank you all again for the time and attention that you provided here. It's awesome conversation, awesome talk.
Thanks, Dr. Cooper-Williams, and thanks to all of you, Dr. Hart, Dr. King, Dr. Silva, and Dr. Thomas for joining us today. Certainly this conversation for now is taking a pause, but the conversation will continue, and the work together to improve health equity and patient safety, quality, and care will continue to move forward. So I look forward to keeping the conversation going and want to thank all of our attendees for joining us today, and hope to see you next week or at another one of our summer roundtable sessions.